Assalamu alaikum. Here are some principles in the clinical examination of the child with respiratory disease. The emphasis differs depending on the age of the child. The younger the child, the more important is the phase of inspection, and the more difficult are palpation and percussion, and the less informative is auscultation. When examining neonate or infant, observation provides 90% of the information. Don't undress the infant until you know the following: the respiratory rate, the color, presence of nasal flaring and use of accessory muscles, presence of stridor where inspiration is longer than expiration, and the presence of wheeze where expiration is longer than inspiration. In infants and young children, palpation and percussion are not part of routine examination except to assess the degree of hyperinflation, to detect the upper border of the liver, to confirm signs of consolidation, collapse, or effusion. And also, chest expansion is pointless here, since the chest is circular and the breathing is diaphragmatic and abdominal. Also, respiratory distress is reflected by abdominal movement mainly. At the start of the exam, you should introduce yourself and role to the patient. Meanwhile, you note the child voice. If there is hoarseness of voice, like what is seen in a group, and you can do it like this. Hi dear, I am Ali, one of the final year medical students. Can I just have your name and date of birth, please? Nice to meet you. I have been asked to examine your chest. Looking from the end of the bed, feeling your pulse and chest, listening with a stethoscope at the end. Would that be okay for you? Have you any pain anywhere at all? Have you any question about the exam? Okay, we can just start the exam. And then stand back and give general description of the child. The chest should be fully exposed except in adolescent girl and infants to avoid upsetting. See if there any sign of malnutrition, which is seen in cases of cystic fibrosis, bronchopulmonary dysplasia, malnutrition, and others. And see if there is dysmorphic features, like what's seen here in micrognathia in a case of Pierre-Robin syndrome. Note whether the child is well or unwell. Is he dyspneic, dehydrated, having severe malaise, lethargic, or in pain? Is he cyanosed or not cyanosed? Any notable respiratory noise like stridor, wheeze, cough, and nature of the cry also can be noted. Look for severity of respiratory distress, whether there is intercostal recession, subcostal, sternal retraction like in infants, and the tracheal tag. Look also for degree of dyspnea and the number of words he can speak before having to take a breath, or ask him to count to the highest number he can. Count also the respiratory rate. Counting the respiratory rate is very important in evaluating the state of dyspnea of the patient. We should know the upper limit of normal respiratory rate in infants and children, and here is the upper limit of respiratory rate in neonates is up to 60, in infants up to 40, 1 to 3 years up to 30, 4 to 10 years up to 25, and more than 10 years up to 20. And looking for cyanosis, the definition of cyanosis is reduced arterial hemoglobin of more than 3 grams per deciliter or capillary hemoglobin of more than 5 grams per deciliter. Could be either central cyanosis or peripheral. The central cyanosis is caused by arterial hypoxia, or there is normal level of arterial oxygen in methemoglobinemia or superior vena cava obstruction. Peripheral cyanosis could be caused by vascular causes or hematological. The vascular, like vasomotor instability, in hypothermia, in venous obstruction, in shock, hypoperfusion with venous stasis, and the hematological could be due to polycythemia. And then ask the patient to bring his hands in front of you to see if there is any clubbing or peripheral cyanosis, or there is cannula scar, or tremor, side effect of beta agonist overdose, or if there is astraxis, which is the flapping tremor due to CO2 retention. You can measure the pulse for tachycardia, for pulsus paradoxus, like in cases of cystic fibrosis and asthma, or cardiac tamponade, where the difference between inspiration and expiration and blood pressure exceed 15 millimeter mercury. And examining for digital clubbing and Shamroth sign, you ask the patient to bring his fingers together and show him how to bring them to see if there is angle opened in clubbed patients or normally diamond-shaped hole in between the nail beds of the two fingers. And as you know, digital clubbing can be pulmonary, cardiovascular, non-cardiovascular cause, or familial cause. From the pulmonary shunting and inflammation, bronchiectasis could be the cause, severe pneumonia, lung abscess, empyema, interstitial lung disease like autoimmune lung disease and infectious, pulmonary arteriovenous malformation, and hepatopulmonary syndrome, where chronic lung disease causes vasodilatation of the pulmonary arteries and end with this condition. The cardiovascular causes cyanotic congenital heart disease and bacterial endocarditis. The non-cardiopulmonary causes like inflammatory bowel diseases, thyrotoxicosis, and the last is the familial cause of clubbing. In examining the face of the patient and the mouth, we look for presence of pallor, central cyanosis, the undersurface of the tongue, presence of any dysmorphic features, or cushingoid appearance, or if there is a cleft lip and palate. And then we ask the patient to sit forward to consider cervical lymph node examination, trachea, if it is central or deviated, and the presence of tracheostomy or tracheostomy scar. Here are some of the respiratory patterns might be seen in children or adolescents with respiratory disease. The normal, we should be familiar with the normal respiration, where inspiration and expiration are almost equal. And the hyperpnea, called cosmal breathing, it is rapid and deep breathing, seen in metabolic acidosis and hypoxia. Or the shallow and rapid respiration, which is seen in restrictive lung disease. What's called biot respiration, irregular respiration with alternating hyperpnea and apnea, seen in meningitis, encephalitis, other CNS lesions. Chinese talk respiration, repetitive increasing and decreasing respiration over 30 minutes, seen in coma. Abdominal breathing, which is normal up to 6 years of age. Paradoxical respiration occur in respiratory muscle weakness, upper airway obstruction, pneumonia, obstructive lung disease, and prolonged expiration seen in bronchiolitis, acute asthma flare-ups, and cystic fibrosis. Look if there is oxygen administered to the patient, and this could be through nasal cannula, which is seen here on the left side, simple face mask or the Venturi mask, which is seen with colored adapters here, and the reservoir bag mask on the right side. The nasal cannula is used for low to moderate oxygen requirement. It gives oxygen of 2 to 6 liters per minute with FiO2 of 40 to 50%. The simple face mask, low to moderate oxygen requirement, 5 to 10 liters per minute with a variable FiO2. And the Venturi mask for moderate oxygen requirement with a flow rate specific to adapter diameter up to 12 liters per minute with FiO2 of 24 to 60%. And the reservoir bag mask with 12 to 15 liters per minute with FiO2 of 60 to 80%. Look around the bed and on the tables if any of the following can be seen. If there is inhaler, nebulizer, or other medications like special medications like in cystic fibrosis, as you see here, Creon, which is the lipase enzyme used regularly in patients with cystic fibrosis. You can see here the nebulizer in the middle and the spacer with mask on the left side and the oximeter on the right side. If there is IV line and what is given through that IV line. Other tubing like nasogastric tube, monitors and their readings, other useful signs like a wheelchair around, sputum pot or peak flow meter. Ask the patient to take a deep breath to see the symmetry, the chest wall symmetry, shape and the movement. It might be asymmetrical in cases of right ventricular hypertrophy, pneumothorax, scoliosis. See if there are scars from the front and the back. See if there is sternotomy, thoracotomy, for lobectomy, for diaphragmatic hernia repair, for PDA, coarctation of aorta repair, or for blaloctusic shunt put before. If there is chest drain and its scar also should be seen. Central lines, there is Ped Clin side, peripheral inserted central catheter, which is seen here on the right, and the Hickman line, which is the central venous catheter seen on the left side. Look for presence of signs of rickets like rachitic rosary, that is swelling of the costochondral junction, or presence of Harrison sulci, which is retracted costal cartilage at the level of the diaphragm in poorly controlled asthma, cystic fibrosis, and pulmonary fibrosis. Look also for pectus excavatum, which is funnel chest, which may falsely accentuate severity, mimic sternal tractions, and for pectus craniatum, the pigeon chest, and look for the spine if there is kyphosis or scoliosis. We start palpation by noting the tracheal position. Ask the patient, let me feel your windpipe and see if it is displaced or not. And then tell him you are examining his chest expansion. So say, I'll place my hand around your chest quite tightly and then asking you to take a deep breath in and out from back and front, except in infants. And then examine the apex beat if it is displaced or in its normal position. Note that the second rib is attached to the sternal angle and see if there is parasternal heave due to right ventricular hypertrophy or palpable pulmonary valve closure in pulmonary hypertension that might occur in cases of cor pulmonale in advanced cases of cystic fibrosis. And tactile fremitus is difficult to assess in children and better to be omitted. For percussion, warn the child first, saying that I'll tap your chest. Ensure symmetrical percussion. And be sure that you are using the pleximeter and the plexor fingers properly. Strike 2 to 3 times in each position and don't dampen the sound. Percuss over the same zones as auscultated. And note that the apex best percussed from behind and the axillary with child hand on his or her head. Here are some of the percussion notes. It's either resonance, called vesicular resonance, which is normal, or hyperresonance, somewhat similar to tympani, hyperinflation and emphysema, asthma and pneumothorax, or dullness, flat thud-like sound, pleural fluid consolidation, flatness, stony dullness, mimic percussing over a muscle, massive pleural effusion, where Tobey's space and the sixth space midclavicular line and eighth space anterior axillary line, it's normally tympanic. It's due to the stomach air bubble. If this area is dull, it might be due to splenomegaly, that is the Castelli sign. And now tell the patient that you are going to listen to his chest and tell him, if you please take a deep breath in and out through your mouth. Note that the upper lobe best heard anteriorly in the infraclavicular region, and the lower lobe best heard posteriorly below the scapulae, and the right middle lobe and lingulae best heard anteriorly lateral to the lower third of the sternum, and all lobes can be heard in the axillae. And here is the description of some of the breath sounds. First, vesicular breath sounds. It's like rustling and whooshing sound. It's normal. The bronchial sound is louder than vesicular, with short inspiration and long expiration. It's seen in consolidation or compression, in airlessness of the parenchyma. The bronchovesicular sound is in between vesicular and bronchial. The wheeze is a continuous musical sound, usually with short inspiratory and long expiratory phase. It's either monophonic or polyphonic. The stridor is a musical monophonic, usually inspiratory, can be inspiratory and expiratory. If severe fixed obstruction, usually produced by partial obstruction of the central, typically extrathoracic airway. For the voice sounds, the normal lung parenchyma filter vocalization so that the whisper sound are not usually heard during auscultation, and normally spoken syllables are indistinct. It's called bronchophony when the distinct transmission of the spoken syllables, when the patient say 99, is heard, and that is seen in consolidation or compression or both. And it's called whispered bacteriology when the transmission of even whispered syllables is heard. And there's what's called egophony with nasal quality. It's like the bleating of the goat. When you tell the patient say E, you will hear it ah. This is seen in consolidation, compression, or both. For the adventitious sounds, we start with fine crackles, rails, or crepitation, occur due to explosive opening of alveoli that closed during previous exhalation, occur exclusively during inspiration, in bronchitis, pneumonia, atelectasis, and pulmonary infarction. There's what's called Hammond's sign, or mediastinal crunch. It's associated with systole in pneumomediastinum. And there was called squawk, short inspiratory wheeze in association with fine crackles and explosive opening of a large airway. For coarse crackles, or rails or crepitation. They are popping sounds produced by movement of thin fluid in bronchi and bronchiole. They occur early in inspiration and occasionally in expiration as well. They are typically heard in cystic fibrosis and pulmonary edema. And about pleural friction rub, which is a loud grating sound, may come and go over a short period of time. It's due to subpleural parenchymal inflammation. And note also that peristalsis can be heard in the chest in patients with diaphragmatic hernia. You can say at this stage, to complete my examination, I'd like to plot height and weight on growth chart, see the peak flow meter of the patient if indicated, and see the oxygen saturation and the blood pressure of the patient, and do abdominal examination if indicated for liver especially or spleen, and cardiac examination if indicated in cases of cor pulmonale, and examine the ear, nose, and throat. For the ENT examination, examine the ears for their shape, size, and dimorphism. Examine the nose for polyp, deformity, or deviated septum. Examine the throat for cleft palate or tonsillar hypertrophy. You should note that you should do exactly what the examiner asks. If the question is examine the respiratory system, that includes examination of the hands, of the chest wall, of the lungs, of the ENT, and of lymph nodes. If the question examine the chest, that includes chest wall, heart, lungs, and more peripheral signs. Note that some prefer to examine the anterior chest wall completely and the posterior aspect of the chest completely, or do percussion of the front and back and then auscultation in the same manner. There is no right or wrong way to do it. Stick to one method to which you are comfortable. I'm looking forward to see you practicing this efficiently. Good luck.